Assalamu alaikum, the clinical day. The first scenario, Mrs. Julia Adam, 56 years old, female, came to the clinic due to skin rash. Please examine her, address her concern after taking history, and provide her the management plan. Ready, Dr. Lemia?
إن شاء الله.
Okay, here you go.
Hello.
Hello.
Hello. I'm Dr. Lamia, the doctor of the clinic today. May I confirm I'm speaking to Mrs. Julia Adam, 56 years old?
Yes, I am Mrs. Julie Adams, 56 years old.
Hello, Mrs. Julia.
Hello.
Mrs. Julia, we are here today to discuss issue related to your health condition. Is it okay for you?
Yes.
I will ask you some question and also I need to examine you. Okay?
Okay, proceed, doctor.
Okay. Also, I might need to take some notes and be sure it will be confidential and all my attention will be with you.
Okay.
Mrs. Julia, it came to my knowledge that you are suffering from a skin rash. Is it right?
Yes.
Can you tell me more about that?
Actually, just 1.5 months back, it has been noticed by my colleagues at my work that I have this rash and enlarged. But now it is size is not increasing, but I feel worried regarding this rash because the disfigurement it may make me stress a lot.
I'm sorry for that, Mrs. Julia. Can you tell me where exactly this is skin rash?
It is in my right axilla.
Okay, since it started 1 month, 1.5 months ago, it is the same.
It was small and then it enlarged, but now it is not enlarged. It is like disfigurement with the skin. There is irregularity over the skin, like it will be the velvet or something like that one. Only this, and the discoloration it is black, dark. I feel really stressed regarding this rash.
Okay, Mrs. Julia, can you tell me this rash is blanchable or not?
I have not touched it a lot, but it is same color, not changing.
Okay, it is associated with rash in other site?
No other sites, doctor.
Do you think anything increases rash?
Nothing. Nothing.
Anything improving it?
Nothing. It is the same.
Any associated symptom with this rash?
What symptoms you mean, doctor?
Any joint pain?
Sometimes I have knee pain. Sometimes.
Any oral ulcers?
No, I don't have.
Any bowel change? Any loose motion?
But what you mean by bowel change? Lose motion?
Yes.
No, I don't have loose motion. Sometimes I have constipation.
Do you have any change in your weight?
Yes, I lost about 5 kg last 2 months.
Okay. Any fever, high body temperature?
I don't have fever.
Any lumps or bumps in your body?
Lumps or bumps? No, I have not felt any bumps or lumps.
Any night sweats?
Sometimes I have a sweating, especially in my hands.
Okay. Mrs. Julia, do you have any past medical history?
Past medical history. What do you mean by past medical history? Regarding the surgery or
Any chronic medical disease, like diabetes, hypertension, any relevant medical history?
just 1 month back, they told me I have high blood sugar. And I started now to take oral treatment.
Before this month, nothing.
Nothing. Just I have this skin rash, and
Same period, yes.
I felt there is increasing frequency of my water work. So I test done for me. They told I have a high blood sugar and started me on treatment called metformin.
High blood sugar?
Yes.
Your blood pressure is okay?
Also, they told me I have elevation of my blood pressure, 150 over 90. Also started me on medication called cabotine.
Okay, do you have any surgical history?
I don't have any previous surgical history.
Any history, previous admission in hospital?
Previous admission in hospital? No. Also, nothing before.
Okay, do you have any other medication other than this cabotine and metformin?
No, just this medication that I am receiving since the start of the rash, this disfigurement.
Okay. Any history of drug allergy?
I don't have.
Any family history of similar condition?
Similar conditions, you mean like high blood sugar and high blood pressure? I don't have high blood pressure or high blood sugar or this rash also. No.
Any similar history of notes? Similar history of notes, يعني family history of notes, rash.
What mean by not?
Any familial disease, any disease run in family.
No disease run in family. My aunt, she has cancer uterus.
Okay. Any travel history?
Yes, I traveled to Africa, Zimbabwe.
Since when?
That one about 1 year back.
Do you received any prophylactic medication or vaccination before?
No, I have not received.
Where is your residency, in hotel ولا in friend house?
Residency, you mean?
Yes.
This hotel, I went there with my family, and there it was a hotel. Actually, I left my husband there in the UK, but I went with my daughter Sandra only. We are only went there.
Okay. From where you received your food?
My food, actually, I received from the grocery my food, and we are not eating in the restaurants. All food we are taking at home. You mean where I was there in Zimbabwe or here in UK?
In your traveling.
In Zimbabwe, yes, the hotel food.
Okay.
It is a 5-star hotel and it is very clean food.
Okay. Any history of sexual any sexual activity there?
I'm sorry to tell regarding this, although I am Catholic and religious, just yes, there is one extramarital done.
Any history of insect bites there?
Insect bite? No.
Okay. Any history of tattooing, piercing, or receiving a blood transfusion?
No.
Okay. Do you have any headache?
Yes, sometimes I have headache.
Where exactly?
This headache, it is all on my head, especially the front and the sides.
What increasing, what decreasing this headache?
Nothing exactly. Sometimes I feel this headache, I feel the high blood pressure. Sometimes it come even without this high blood pressure.
Do you have headache now?
No, now no, I don't have now.
Do you have any low mood or lack of sleep? Memory affection?
No memory affection.
Any vision affection?
Yes, the lateral field of my vision is affected mainly.
Okay. Do you have any a weakness or any change of sensation anywhere in your body? Abnormal sensation?
I don't have abnormal sensation, but I feel also some weakness, especially in my shoulders.
Okay. Do you have any neck swelling?
I don't have.
Any call for shortness of breath?
No, I don't have shortness.
Any heart racing, palpitation, heart racing?
Heart racing. Sometimes with the high blood pressure, I have this.
Okay. Any tummy pain or discomfort?
Tummy pain. No, I don't have tummy pain.
Any
It
change
is
in your water
normal.
work? Okay. Any change in your water work?
Yes, because of the high blood sugar, I have this changes on my water work.
Any change in your shape of the face?
My colleagues told me that I look more bigger than before, but really the most distressing me is this rash. But they told me your head become more larger than before, but my daughter has not noticed this. Maybe she, because she's living with me, I don't know.
Okay, Mrs. Julia. What's your job?
I am a basketball player.
Is this affect your job?
Yes, it is affecting me. All my colleagues, they see this one. They told me, what is this? Because this our clothes, my armpit will appear.
Okay.
1.5 minutes
Okay.
remaining.
Okay, Mrs. Julia, I can refer you to occupational health to help you as regards this issue, and also I can give you sick leave till we'll reach the bottom of your condition. Do you smoke, Mrs. Julia?
Yes,
How many cigarettes for how long?
5 cigarettes per day since 7 years.
Anyway, Mrs. Julia, smoking is dangerous for your life. I advise you to stop smoking. Okay, I can help you
Okay.
by referring you to smoking cessation clinic. Do you drink
Okay.
alcohol?
Socially.
Okay. Do you drive?
Yes.
Okay, just now I advise you to stop driving because may harm you and harm others. Okay.
Okay.
Can I examine you, Mrs. Julia?
Yes.
Vitals?
Vitals, just blood pressure 150 over 90. Okay.
Okay.
I
Uh,
will make it share of the photos.
okay.
What you'll examine?
I'll examine your hands.
Okay.
Any change in size of your hands?
Also, they told me my hand become bigger than before.
Okay. I need to do this is a tunnel test for carpal tunnel is positive.
Okay.
Okay. Can I examine your shoulder for proximal myopathy?
Shoulders. Yes, you can.
I
I
asked
send the photos on the WhatsApp. Sorry, to not you can see in the WhatsApp same group.
which group?
I share it here
Dr.
in the
Kamal.
chat box.
Okay, thank okay.
I share it to the chat box. You can see it down in
Okay.
the chat.
I saw, okay. Is there is proximal myopathy? Positive
Yes,
okay.
there is proximal myopathy. Yes.
Okay, I examine the face. There is a frontal bossing or
Yes,
eyebrow
there is. Yes,
prognathism in your
yes, there
I
is.
I need to examine the eye for acuity.
Yes.
Uh, Nothing in visual acuity. Visual field by each shape movement.
I think time finished, or what's your opinion, Dr. Bassam? Or can give
Yeah,
again?
we'll extend because first time for Dr. Lamia. We'll extend
Okay.
3 more minutes.
Okay.
Go ahead, Dr. Lamia.
Thank you. I examine the field for each shape movement.
Yes, you
There
will
is-
find by temporal hemianopia.
Yes, I examine the. I offer examining the fundus by ophthalmoscope. There is
Okay.
papilledema.
Mild.
Okay. I examine the neck for any swelling, thyroid swelling.
No thyroid swelling.
Mouth also, please. I will examine for interdental spacing, large tongue.
There is large tongue. Yes.
Okay. النك no thyroid swelling, elevated GVP.
No GVP.
Okay. Any lymph node enlargement.
No lymph node enlargement.
الهارت الشست no abnormality auscultation
Chest
palpation.
no. Chest auscultation in front, no abnormality.
الباك any abnormality. basal crepitation.
Fine crepitation, but changing.
changing.
Yes, with cup.
Okay. الهارت.
Heart, there is pansystolic murmur in the apex.
Okay. Any other abnormality in the heart? Nothing.
Nothing.
Okay.
Just this.
Okay. الابdomen any abnormality, any organomegaly.
There is hepatomegaly about 4 centimeter.
Okay.
The spleen normal.
Okay. I need to examine knee
Yes.
for any crepitus.
Yes, there is crepitus on the right knee.
Any lower limb swelling.
No lower limb swelling.
I already saw the rash. What's your concern, Mrs. Julia?
What do I have, doctor?
From what you told me and from my examination, I say mostly you have condition related to your gland in the brain, which is secreting protein called growth hormone. This lead to this all symptoms that you suffered from. We need to do some lab investigation and imaging, and we'll go back to you with the result in another meeting. Is it okay for you, Mrs. Jolie?
Is it okay? But I wanted to ask regarding do I have cancer, doctor?
Um, we will do some cancer is likely in your condition, Mrs. Julie. I'm sorry to tell you that, but we need also to do this investigation and scan to be sure from the result, and we'll come back to you. But I need to ask you some question, if you don't mind.
Okay.
Any passage of blood with your stool?
Yes, I have blood in stool since 1 month, but it is not all the time. Sometimes mixed with the stool.
Thank you, Mrs. Julie.
Okay. Well done. Perfect, Dr. Lamia.
Okay,
We can
excellent.
start. Yeah, we can start now. Examine your question, Dr. Ahmed, please.
Okay, what is your differential diagnosis?
The most possible, it is pituitary adenoma. It's the first differential diagnosis. يعني.
Okay. This is your diagnosis.
Yes.
The differential diagnosis is pituitary
Differential
adenoma. Yes, for
Yes,
differential diagnosis.
Yes.
What else it can be?
This axillary rash دي acanthosis صح؟
Yes, the acanthosis nigricans.
Nigricans, yes.
Okay.
This is maybe with Cushing, Cushing, any cancer stomach. بس against this all nothing يعني with this result except weight loss. Cushing maybe PCO بس is الage
Okay.
Cushing, PCO, cancer stomach.
Okay.
What else?
Okay. What is your treatment?
Main treatment because there is management mostly will be referred to multidisciplinary team, including endocrinologist and neurosurgeon, occupational therapist, social therapist, and first line will be surgery because there is a compression symptom.
Okay.
في medical treatment in the form of somatostatin جروث هرمون antagonist اللي هو بيفيج مش فاكرة I don't remember the name بصراحة.
Okay. Growth hormone antagonist. What else?
Yes. Somatostatin analog.
Okay.
Okay. What else?
Okay. What investigations will do for this patient?
There is baseline investigation in the form of liver function, renal function, electrolyte, CBC, ESR, and also there is blood glucose, hemoglobin A1C, lipid profile, investigation for the cause specific growth insulin-like growth factor 1, glucose tolerance test or glucose tolerance stress test. I don't remember الحمد لله.
Okay.
ده ال confirming test, oral glucose tolerance test. imaging MRI pituitary with contrast.
Okay. What is sorry for also differential diagnosis before? What is your differential diagnosis of the knee pain in this patient?
It may be osteoarthritis due to this increased growth hormone. Osteoarthritis, osteoarthritis maybe.
Okay, it can be osteoarthritis or pseudogout. How will you differentiate between them?
الاسبيريشن جوت كريستال والاكس راي. اكس راي طبعا.
X-ray. Yes.
Okay.
Okay. So what is differential diagnosis of headache in this patient?
Maybe due to a compression symptom and increased intracranial pressure, maybe due to hypertension.
Okay. Okay, the pituitary adenoma, hypertension, maybe obstructive sleep apnea. Okay.
Yes.
What is the differential diagnosis of constipation in this patient?
Firstly, cancer colon.
Okay.
هو في weight
It
loss
can be
ولا weight
cancer
gain؟
colon. في
Cancer.
weight loss, cancer colon. Okay.
Mm.
Others, it can be hypothyroidism associated, and it can be part of men one.
Yes.
So you should ask regarding hyperparathyroidism. In the men one, the hypercalcemia will make constipation.
Yes, yes.
Okay.
Yes.
Okay. Yeah. Okay. Excellent, doctor.
Okay, still 20 seconds, Dr. Ahmed. I will ask here one more question. What
Okay.
the cause of blood in stool?
Cancer, maybe cancer colon.
Okay.
And
Cancer from polyp.
Polyp.
yes, so you have to put differential also for that.
Yes.
Okay. What is the signs of activity of this patient? Or what is the signs of activity of this disease?
الهاند ساينس
Sweating in the hand. Yes.
sweating. Yes.
والsymptoms الهيدك والهاي blood pressure
Hmm.
والvisual problems.
Yes.
Okay. Okay.
And skin
What is
tag.
the indications of
Skin
colonoscopy?
tag also.
Yes, skin tag. Yes.
Okay.
What is the colonoscopy indication in this patient?
colonoscopy.
Yes.
constipation والbleeding بالrectum.
Okay. يبقى colonoscopy at the time of the diagnosis.
Yes.
And if there is polyp, it will be every 3 years. If no polyp, it will be every 5 years.
Okay.
Okay.
Okay, perfect. Thank you, Dr. Ahmed and Dr. Lamia. Well done. Let's hear the comment from Dr. Ahmed, then I will comment.
Okay. Actually, maybe because also first time, also maybe recently started, she was maybe stressed, so she was slowly in taking the history. But actually, she did perfect. However, regarding this rash, I think better to ask from the start regarding the impact on the job. Okay. Yeah, after the rash, because there is no increase or decrease in this rash and no other symptoms. So we will ask the impact of the job, because if you will forget, you will may lose some marks in the communication. You make it at the last of the history. It is good also that you remember. Okay.
Okay.
Other regarding this blood in the stool, just when you came to the symptoms of the GIT, make it all the symptoms of the GIT, ask about them. You asked regarding the bowel habits, but you should ask on the same time regarding the change on the color. Okay.
Okay.
So, but others, you are excellent. Regarding the diagnosis of this investigations, the differential diagnosis is okay. Regarding the diagnosis, we are doing this oral glucose tolerance test. Okay. There will be non-suppression of the growth hormone. Okay. Then will be investigation for the insulin growth factor. Okay. And also we'll do the MRI pituitary to see the pituitary adenoma. This is important also. Okay. Others regarding this patient, she told you in the history regarding the high blood pressure and high blood sugar. But I think when the examiner will tell you what else you wanted to do, I should measure her blood sugar at least and blood pressure. Okay. And also the investigations for complications, we should do also the chest X-ray if there is cardiomegaly, because he has this mitral regurgitation. Okay, ECG also should be done regarding ischemia, or also diabetes and hypertension, and also pituitary function test, TSH, ACTH, prolactin, testosterone, glucose. We already should confirm the hemoglobin A1C already controlled or not this the indications that she's taking, and also a visual perimetry regarding the hemorrhagia. Okay. So only the investigation may be that one, but treatment you make it perfect. Also, we can add also the causes of macroglossia in the differential diagnosis, like acromegaly, amyloidosis, hypothyroidism, and the Down syndrome. Okay. And also the acanthosis nigricans. This is velvet-like skin changes. Okay. Commonly in the axilla, association with obesity, type 2 diabetes, acromegaly, Cushing syndrome, ethnicity, Indian subcontinent, and the malignancy, especially adenocarcinoma. Okay. The other thing we should ask regarding the men one. So that one important to ask regarding the hypercalcemia symptoms, because it is associated. Okay. Other one, I wanted to add the differential diagnosis for bitemporal hemorrhagia. It can be pituitary adenoma or craniopharyngium. Okay. But it is excellent, doctor.
Thank you.
Okay, thank you, Dr. Ahmed, for the case, and
Yes.
well done, Dr. Lamia. You did perfect as first time. I added time just to give you some confidence. I know it's difficult and stressed to do this meeting and to practice in this number. Although you might have a larger number, some meetings having a larger number if you want to practice with any mentors. But it's a good idea to start with this meeting. Anyway, you did great. I will comment about the history taking. You started organized, but I will ask you some, or I will give you some advices regarding the rash. Whenever you hear about rash and complain, ask the patient to show you the rash. You will be narrowed in the differential. From the start, whenever you hear there is rash, in this scenario, if you ask me or you ask Dr. Ahmed, I will share that photo and you can know the diagnosis from the first question. Although you have to ask about also the rash, what increase, what decrease, what make it better, what make it worse, all this question, the distribution, any oozing, any sensation over it, like that. But still, the idea of showing you the rash is the must. You have to ask it to narrow your differential.
Okay.
Okay, this is the first thing. The second point or the second advice, you made the last thing system review, or maybe because of course, if you speed up your questions, you might have good time to examine the patient. But your approach was okay. You started by the onset, course, duration, the relevant system, then the associated symptoms, then the constitutional symptoms, which is loss of weight. You have loss of weight here, and you ask about everything related to the constitutional symptoms like night sweat, body temperature, and also lumps or bumps, which is good. I will add some advice in the family history. Be clear and give him clear question. What you want to ask about? If not, what you mean by not? Is it cancer? Ask cancer. Is it gland disease? Ask gland disease. So either to start by giving wide question, then narrow your question if he didn't understand you. So you can tell him about gland, about cancer, about what you suspect in your mind. It's okay to ask him. So you suspect here acromegaly. Ask him clearly, you have any cancer or gland problem in your family? Or a skin rash. It's okay to ask about skin rash because this is the main complaint. You want to ask about bladder, or sorry, colon cancer, you can ask any cancer in the family, any heart disease, any. So be clear. Don't give him a question and he will ask you what you mean. Then you will tell him anything, any note. No, specify what you want to ask about. Okay.
Okay.
Then for the sexual history, don't say you have any sexual activity. You can say, sorry for this question before asking this question particularly, and you will tell him, you have any casual relationships or extramarital relationships? Sorry for this question again. Okay. Female history, you miss here the female history
I missed this.
totally, which is important. Yes. Because if you have panhypopituitarism in this patient, she might have amenorrhea.
But this is 56.
Cool, mom. Yes, even you can ask her previously any problem in your period, any miscarriage, any pregnancy, like that. Okay, you might have Sheehan syndrome with panhypopituitarism. Only three questions for the female history, as we know. Three P's: period, pregnancy, and OCPs. Okay.
Okay.
The last thing for examination, you did all steps of examination, perfect way and perfect manner. From the hand, going to the face, the eye, the vision, the visual fields, the tongue, the face, facial features, and for the chest also, heart failure, the murmurs, abdomen for hepatomegaly, and lastly for the knee. But don't miss the rash. I noticed you examined, or you said lately that you saw the
Before
rash. Yeah,
mm,
but this is the main complaint. Don't miss it.
mm,
You can start after examining the vitals, show me the rash, and examine the rash.
okay.
Apart from this, even in the discussion, you answered well. The topic is very classic case of
Mm,
bases.
mm,
Acromegaly, either associated in main one or isolated, it's classic case. The steps also of examination, you have to mention and you have to do all of them. It started from the hand, the sweating, the dorsum, and the blood pressure, carpal tunnel, as you did exactly. Sorry, proximal myopathy, the face, the features of the face, the tongue, the neck circumference. Even you can ask acanthosis. You can ask in the neck, and in the
mm.
axilla and the groin. You can offer examine all of them. Don't strict to
Okay,
the
so
area
sorry to
of.
add,
Yes,
Dr. Bassam,
yes,
also
yeah.
saying
Go ahead.
we should also regarding the HIV also, okay, because maybe she has colorectal cancer and HIV will lower the immunity, make other viruses to occur and making this carcinoma. So HIV also we should ask regarding to offer on the test, I think, in the
No,
investigations.
no, it's not necessary as a test
Yeah.
investigation. You know this is the case of acromegaly clearly. I don't think there is possibility for HIV here. You mean after the casual relationships?
No, no, because of the she has this colorectal carcinoma mostly because of the blood. So most of her immunity is lowered also. So other viruses like
If
Epstein-Barr virus predisposes them to carcinogenesis.
no, if you want to make a relation between the extramarital relationship, yes. But I don't know. I'm not sure about the HIV related to cancer colon as a trigger. You mean, right?
Yes, yes. Also, she has this cancer uterus in her aunt. It can be also this Lynch syndrome.
Yeah, Lynch syndrome.
Yes,
Exactly. Yes.
uterus and the colorectal cancer.
Yeah.
Mm.
Perfect. Once you know that this is a case of acromegaly, don't miss the blood in stool and back passage, and to offer digital rectal examination. It's very important. And he
Yes.
mentioned to you constipation. You have to analyze the constipation. What make the constipation worse? What make it better? How many times? And if you don't have suspicious for gastroenteritis, don't go more in detailed history about the taking
Travels, huh?
food, the food history. You ask about food
Uh,
history. I don't know.
travels, huh? I
Yeah,
want
the
to ask
travel
you.
and
Mm,
okay, you can ask the travel for skin rash in insect bite accepted if you have skin rash, but it's not
mm,
skin rash for skin insect bite, right?
okay.
If you want to ask, you can ask about malaria. It makes sense to ask about malaria vaccination before traveling to Zimbabwe, rather
Mm,
than asking about the food, because no any history of GI symptoms in this patient apart
yes.
from the constipation. So if you have diarrhea, yes, you can ask about
Yes.
the food nature during the trip. Okay.
Okay. Okay.
Let's open the discussion. Anyone has, before that, any question, Dr. Lamia?
No, but
Any question?
if I ask it
Okay.
to see the rash, it will be totally different, especially in taking the history.
Mhm.
But,
Exactly, yes. Even you
mm,
can go to see the rash and come back to the surrogate to continue the history.
mm,
But you will be targeting the questions. خلاص,
yes,
you
yes.
know this is cancerous negligence, and you are targeted to acromegaly or Cushing or some endocrine
Till
condition.
I reach the system review, I didn't have anything about the diagnosis. Yeah.
Yes, mostly because you didn't see the rash.
Yes.
So it will make
Really, it was
it make
difficult
you
case.
easy.
Yeah.
Yes, it's difficult, but it's
Because
classic.
symptom.
I
Yeah.
thought cancerous nigricans, but when Dr. Ahmed told there is weight loss, يعني
Yeah,
the diagnosis went away from my head.
it's okay. I will advise you. Some classic cases and bases you have to practice them even with one partner, not in meeting. One of them, the acromegaly. And by the way, the steps of examining acromegaly, you have to do it either on any relatives or any patient because it's a very high yield topic. Acromegaly and main one, very high yield topic in the exam. You have to know it before any exam to do the steps and to take history with partner. How to take history about acromegaly, all presentation of acromegaly. By the way, it's not
Yes,
not only the as here skin rash. You might have headache. As Dr. Ahmed said, the differential of headache in acromegaly is very wide. Either high blood pressure or the growth itself, macroadenoma itself, or obstructive sleep apnea. So you have to know how the acromegaly might present in the exam and to take history related to the acromegaly, whatever the complaint. Okay, osteoarthritis, knee pain, it might be as a complaint. Constipation, any parathyroid symptoms or hypercalcemia symptoms, again related to min 1, and acromegaly will be associated. And whenever you answer the investigation, please make it systematic. Don't say, I will do general investigation, liver function, kidney function. No, you can say in order general, specific, non invasive, or imaging. Bedside, sorry, let's say, count it again. General, specific, bedside test, and non invasive ultrasound or imaging, invasive test, and you can say investigation for complication. In such scenario, you have to mention investigation for complication, which are diabetes, hypertension, maybe also you have cancer colon, so you still under the term of non-invasive and then invasive. Non-invasive, you can do CT. Invasive one, you will do colonoscopy. But if you systemize the answer like this, better rather than saying general investigation, liver function, kidney function. So you don't know what you are saying, and you'll waste time without mentioning the specific test. Here you have to do specific test. As Dr. Ahmed said, insulin growth factor, like one, insulin, growth factor. Then the oral glucose to confirm the test, to confirm that diagnosis. This is the specific. The bedside, you can say, as Dr. Ahmed said, echo, ECG, ultrasound, all these bedside tests, urine dipstick, blood, stool analysis for blood. And also you can add to the specific tests, genetic testing for min one. So you have a lot of investigation. Don't strict yourself to general investigation, kidney function, liver function. It doesn't make sense to do such test without mentioning the specific. Yes, we will do it, but in the exam, they want to know what you are targeting. You are not doing everything for nothing. You have to do the specific for your possibility as a diagnosis. Okay?
okay, okay.
Any question else, Dr. Almia?
No, thank you. شكرا.
Okay, any question, Dr. Ahmed, or any comment?
No, thank you. Excellent.
Okay, yeah, Dr. Lamia, please write the scenario down in the chat box or send it to me. I will write it and we will open the discussion. Any comment from our colleagues? Dr. Al Rashid, I think he want to add any comment here, please. Dr. Rashid. Anyone has comment, he can comment. Or I will read the comments in the chat box. Okay, Dr. Al Rashid wrote, it's better to have a look for the rash and continue. Yes, I agree for this advice. Sorry, I missed part of the history. Dr. Hatem, why he should stop driving? It's important here, as Dr. Lamia did perfect and complete history taking. If she can manage the time, it will get the full mark. Okay, so driving here because of bitemporal hemianopia, you have to stop driving. Okay, Dr. Ibrahim wrote it's usually benign. Okay, he mean I think adenoma. Yes, it's benign adenoma. Did the candidate say it is it in the history or in the examination finding? She advised him to stop driving before doing the examination. No, no, she got the history and she asked clearly about the vision, and he said, yes, I have loss of the vision to the lateral side because of vision affection in the history. Yes, exactly. Thank you, Dr. Sarah, for clarifying. Perfect, Dr. Bakinam. Great, you and saying perfect, Dr. Lamia. Yes, she did perfect. Sorry, I missed most of the case. Dr. Zainab. What was the diagnosis? Acromegaly, isolated one, without any association with men. But we have to screen for men one. Whenever we have pituitary, we have to screen for pancreas and parathyroid. Okay. Dr.
دكتور
Ibrahim,
باسل.
أهلين. Yes, Dr.
يا هلا يا هلا سلمى.
Dr. Salma, yes.
Uh, I have one comment
Mhm.
only. A lot of people, when they are explaining the concern, answering the concern of the patient, explaining the disease, they just explain the condition without mentioning the name of the condition, as Dr. Lemia did today. You have a problem in one of the glands. She explained perfectly, but she did not mention the name of the condition.
Yes,
I
you're
think
right.
they want to mention the name of the condition for any patient. This in the exam and in the normal life. The patient want to go and read about his condition. That's
Yes,
why you have a problem, which you call in medicine acromegaly. It could be alone or as a part of other problem. It's a problem in your glands, blah blah blah, as she explains
yes.
perfectly.
Agree, yes, agree with you.
Yes.
So this is general advice not only for Dr. Lamia, for anyone will answer a concern, mention the name of your disease possibility. It's okay to say it, and if he asks you what is it, you can explain it later on. But don't just give him the explanation without mentioning the disease name. Okay, your scenario, Dr. Ahmed, you are the pulmonology specialist in the clinic today. Mr. Hani, 31 years old, referred to you from the GP complaining of productive cough 7 weeks since 7 weeks and headache for your kind care. I will share the scenario now. Any other comments? Please feel free to comment. Travel to Zimbabwe. I think it was distracting, right, Dr. Ahmed?
Zimbabwe for to ask regarding the HIV,
Okay.
because 1/3 of these people, Zimbabwe and Botswana, they have this HIV positive.
Oh,
So just you
most,
will hear this one, you should ask regarding HIV.
yeah, most of Africa countries, especially the North country.
Yes.
Okay, on examination, look for the skin tags. Yes, this is one of the activity of the disease. Skin tags, hypertension, and sweating. Dr. Gouda, no relation to CRC. That clear may be related to lymphoma or Kaposi sarcoma, usually in upper GI or small bowel. What's CRC? I know CR7, but I don't know CRC.
colorectal cancer, Dr. Basim.
Okay, colorectal cancer. Yes. Okay. So, Dr. Goda, please, can you explain what you mean by your comment? No relation to colorectal cancer. Between what? The acromegaly, there is relation.
No, because I told them the
I think
HIV
he
lower
HIV.
immunity. It can lead
Yeah,
to lower
HIV.
the immunity, other infections, then it will progress to carcinoma. This is the issue of the HIV.
It's
It will lower the immunity, so other infective agents will come and it will progress like a human papilloma
so
virus.
yeah, I
Also,
get it
as
now.
the
But it's
attacks,
not
yes.
direct like
Yes.
it's the disease itself. Acromegaly itself can lead to acromegaly. Sorry,
Yes.
acromegaly itself can lead to colorectal cancer without thinking about the HIV as a background.
Yes.
Okay. Thank you, Dr. Guda. Really, I didn't understand earlier, but I understand now. High HIV, lower immunity, Dr. Ahmed. Yeah, so lead to other infection like Epstein-Barr virus. Yeah, again, it's not as direct relation with CRC or colorectal cancer. HIV, again, Dr. Hojud. Okay, most common cause of acanthosis nigricans. They will ask about. Perfect. Thank you for this question, Dr. Ibrahim. Let's answer this question. Dr. Lamia will answer this question because this is her case. What are the possible cause of acanthosis nigricans in PACEs? And we can make it as a collection in the group.
Maybe Cushing,
Perfect.
BCO.
Okay.
I think cancer stomach. Or cancer.
Adenocarcinoma هذا هو.
Cancer.
Adenocarcinoma, yes.
Adenocarcinoma. Okay.
Obesity.
Metabolic syndrome.
Metabolic syndrome. Perfect. Yes. Any insulin resistance related condition.
Yes.
So again, let's mention them. You can say
Malignancy.
yes, malignancy. Adenocarcinoma, doctor, already corrected. You can say
I mean
endocrinology.
pregnancy.
Pregnancy. Okay, pregnancy. I heard malignancy. Okay, pregnancy. But pregnancy have another skin rash. I don't
Gravidarum.
think.
Stroia
Yeah.
gravidarum.
I'm not sure about acanthosis with pregnancy. Right? Okay, let's count them again. So endocrinological condition like Cushing, like what else?
BCO
Yes,
metabolic
polycystic
syndrome.
kidney, metabolic syndrome.
BCO polycystic ovary.
Yeah, polycystic ovarian syndrome. And Cushing?
Cushing وmetabolic syndrome insulin resistance.
Okay.
Cancer adenocarcinoma.
Okay, and our case here, acromegaly, but again, indirect way. Any other questions? Dr. Ahmed, when you are ready, let us
السلام
know.
عليكم.
Alaikum salam. Yes, go ahead, doctor.
Acromegaly and BCOS, it is for insulin resistance, I think.
Yes.
Yes.
Right?
Yeah.
Not for the condition itself.
No, not for condition itself.
Yes, both of them for insulin resistance.
Yes, exactly. Any other question? Any comment?
الهدف
Very
معلش
good.
الهدف هل it is a part of activity or not? I'm not sure about that.
The activity signs, headache. Sorry, hypertension, skin tags, sweating.
Yes, and uncontrolled diabetes, uncontrolled hypertension, skin tag, sweating, headache.
Yeah.
Is it?
No, headache. It's not, but it could be related to the hypertension. But I'm not sure by name. Is it as a name or as a association? But as a headache itself, I don't think. Maybe related to the hypertension, indirect way, I mean.
Okay.
Okay. Dr. Pseudo Cushing, yes. Perfect, Dr. Hatim. Pseudo Cushing, also you can add adenocarcinoma, obesity. Hypothyroidism, I'm not sure about hypothyroidism. Hypothyroidism, suppose the skin will be pale unless there is diabetes association. Colonoscopy, Dr. Goda. Colonoscopy is indicated at the diagnosis of acromegaly, whether or not alarm sign for CRC. Yes, as Dr. Ahmed said. So on the time of diagnosis, we will do colonoscopy. And if we have polyposis, we make it more frequent. If you are not sure about the duration, don't mention 3 or 5. Every 5 years or every 3 years if there is polyps. Yes. So just mention frequently monitoring and colonoscopy as a screening and survey. Particularly if the patient is having polyps. But if already he has colon cancer, so he might go for intervention. But the polyposis need to be screened or surveyed program. Please sign of activity. Again, okay, Dr. Hatim. The skin tag, sweating, hypertension.
I think also, Dr. Bassam, we can add the visual problem because it means progression on the tumor if enlarged, the pituitary adenoma. The visual, yes.
I really am not sure about this. But the visual affection as a compression signs and symptoms, It would be
Yes.
the indication of surgery rather than saying this is activity of the disease.
Yes.
Okay, so this is one of the indication for surgery. Okay, if your patient have compression signs or more than 1 millimeter microadenoma, or it become macroadenoma. So less than 1 millimeter, it's called micro. More than one, it's called macroadenoma. Or if the patient is having compression signs and symptoms
I think
like
it's
headache.
centimeter, doctor. It's not
Yeah.
millimeter.
So okay. So 10 millimeter and 1 centimeter. Yeah, you're right. It's 1 millimeter is nothing. So it's 10 millimeter or 1 centimeter. Yes, it is an indication for surgery. Vision also affection, indication for surgery, and we have to know the approach for surgery, Dr. Lamia. How you can do the surgery
Transsphenoidal.
and or sorry, not and or transsphenoidal or
Or what?
yeah, it's recommended to be transsphenoidal, but there is transcranial also approach.
Yes. Okay.
And there is possibility also to add radiation or radiotherapy after
Yes.
or in case of recurrence.
Yes. No.
Okay.
Okay.
بسأل برضه الcomplication of surgery برضه يسأل examiner usually.
Yeah, perfect. Perfect. Let's open all this question, please. Because whenever we have a topic, it's not recur again. Maybe after 1 month to recur again the same topic as acromegaly. And the group may be changed. All of you, inshallah, hopefully you will pass. And maybe the next group will ask another case of acromegaly. So let's open the all possible question in the same session. As Dr. Rashid said, what are the again, Dr. Rashid, what was the question?
Complication of surgery.
Yeah, what are the complication of surgery in this scenario? The common
Then
complication, the commonest.
hypopituitarism.
Perfect. So patient will have
The Addisons will see the postural blood pressure drop. Mostly the
so
Addisons will be all the
all
panel will be
exactly. Yeah,
decreased.
all hormonal dysfunction. Okay, hypothyroidism, Addison, and
Ban hypo. Ban hypo.
yes, hypo. So hypothyroidism, Addison, and
Hypoadrenal.
also hypogonadism. Yes, hypogonadism.
Mm.
Okay, ready now for any
Infection
question?
also. Infection. Diabetes
The other
insipidus.
complication. Yes, yes. Okay, so
Yes.
infection and
Diabetes insipidus also.
okay, and there is one more.
Sometimes I think rhinorrhea, something like that. If surgery is على access بتاعت السيرجري.
You mean local complication.
nasal عندهم access كده مثلا neurosurgery. surgery.
Okay,
Sometimes cause rhinorrhea.
okay, there is one more. You mean leakage of the CSF
It's
through the
leakage of CSF, yes.
yes, perfect. Yeah,
Meningitis also.
meningitis. So
Yes,
Yes.
yes.
right?
Infection.
CSF leakage, infection.
Mostly three things: meningitis and encephalitis infection, and the cranial
Yes.
diabetes insipidus, and the
Yes.
hypopituitarism.
Yes, بالظبط كده.
The most common is panhypopituitarism regarding the paces, but there is also one more we missed. What complication after surgery? Recurrence. It's very important. My patient might have again the recurrence of the growth of the adenoma, right? Isn't?
Yes.
Okay. So I think we discussed the all possible questions in this scenario. Acromegaly or acromegaly in min 1. And by the way, min 1 is autosomal.
Dominant.
Dominant.
Yes, perfect. And the gene is called
Min.
Min.
And the min 2, what the gene name?
Growth oncogene.
RET.
Wait.
Great. Yes.
Red
Great.
gene. And both of them are
Autosomal dominant.
perfect. Is it enough or you want more discussion?
الهيدك ذكرته صح؟ differential of headache you mentioned I think.
Yeah, we mentioned, yes. hypertension, the spreading or enlargement of the gland,
Increasing the cranial tension.
and increase the care pressure, and the last is obstructive sleep apnea.
الهايبرتنشن والبص sleep apnea والهايبرتنشن itself.
Yeah, hypertension, the progression or increase in the care pressure, and obstructive sleep apnea.
I mean hypertensive encephalopathy. I mean.
Okay, hypertension, encephalopathy also, yes, could be. If he ask you what the possible cause of confusion, you can say this hypertensive encephalopathy or increase intercare pressure lead to edema.
Increase intracranial pressure, I think
Okay.
the tumor usually in the cell thoracic, I think ما بيعمل pressure إلا very advanced. صح؟ It is not like
Yes, if
مثلا
enlarged more, yes. Not like space occupying lesion meningioma.
yes, and
Yes,
not
you're
like
right.
مثلا venous thrombosis like that.
Yes, you're right. Okay, I will add last question. What are the possibility and the finding possibly you have in the fundoscopy in this scenario?
Babylidine.
Yeah, perfect. But due to increase in the care pressure again, and the other possible finding, but it will not be in the fundoscopy as you did in the field examination. So by tumoral hemianopia, yes. Okay. I think we discovered most of the questions here. General application. Be ready, Dr. Ahmed. I will read the last comments, then we will start. Dr. Zainab, meningitis, DI, panhypothyroidism, exactly. But panhypothyroidism, better to be mentioned in the first as differential. Please, signs of activity again, Dr. Hatem. So hand sweating, hypertension, skin tag, yes. General complication of any surgery, infection, bleeding, destruction surrounding recurrence, yes, you're right. Take this general complication, perfect. Who's that, Dr. Hatem? So we can make it as general. As also the procedure 2I, 2B, perforation and bleeding, infection and an injury. 2P, 2 eyes. Put it as a rule. Causes of death. Oh my God, Dr. Umayma. Yes, this is another question. Ischemic heart disease, cancer colon. Causes of macroglossia, acromegaly, amyloidosis. What else, Dr. Salma? Hypothyroidism, Down syndrome. You mean in this scenario or scenarios? Macroglossia in general, right? It's not related to the if because of this scenario, acromegaly only the cause. Other causes, amyloidosis as another topic. What else? Hypothyroidism, yes. Down syndrome, perfect. Good differential, really. Thank you, Dr. Zaina and Dr. Salma. I enjoyed being in interaction session. All of them, all of you sharing either by writing or verbally. This is what's supposed the session to be, not only one way discussion. Okay, let's start. Dr. Ahmed, ready?
Yes, ready.
Okay, here you
Hello.
Hello.
My name is Dr. Ahmed. I am one of the lung doctors. Could I confirm that I will speak with Mr. Hani, 31 years old?
Yes, doctor.
Today we are going to discuss some health issues related to your condition, and I am going to take history. I will going to examine you, and I will answer your concern. Is that okay with you?
Yes, doctor.
Okay. It came to my knowledge that you have been troubled with cough. Can you tell me more about this?
Yes, doctor. I have complaining of this long-standing cough for last 7 weeks, which associated with some time with phlegm, which is distressing me.
Okay. It is associated with phlegm. Can I know the color of this phlegm?
It's yellow.
Yellow. No cough of blood?
No,
No cough of blood. It is started suddenly or it is gradually?
started sudden, gradually.
Gradual. Okay. This is the first time or it has occurred before?
First time.
Okay. That one since 7 weeks, you told me.
Yes.
Okay. It increased by anything, increase this cough? You
No.
notice or decrease?
No, it's the same.
Okay. Any relation to the time of the day, either morning or night?
No.
Okay. Any associated chest pain?
No.
Any associated shortness of breath?
No.
Okay. Also, they told me in your notes that also you are complaining of headache. Can you tell
Yes.
me more about this also?
It's non-specific headache in anywhere in my head, not related to anything.
Okay. It started with the time of this cough or before or after?
No, after cough, 2 or 3 days after cough.
Okay. Anything increase it? Nothing, you told.
No.
Okay. Also not related to any time of the day.
No.
Okay. Any associated visual affection?
No.
Hearing affection?
No.
No associated weakness?
Slight weakness.
Where?
Fatigue, not weakness, sickness, feeling sick.
Only feeling. Any fits occurred or faints?
No.
Fits no, faints no. Okay. Any memory affection?
No.
Okay. Any night fever?
No.
Night sweat?
Yes, night sweat.
Okay. Any loss of weight?
Yes, I have lost 10 kilo in this last 7 weeks.
7. Any loss of appetite?
Yes, doctor, I have loss of appetite.
Any bumps or lumps in your body?
No.
Okay. Any skin rash?
No.
Any joint pain?
No. But I need to tell you, doctor, that my GP did some investigation to me and told me that I have low sodium.
Okay. Any pigmentation in your body?
No.
Okay. You are taking any medical treatment before? Right, for any disease you have? Past medical?
No, I don't have any past medical history.
You don't have a low blood pressure before or high blood pressure or?
No.
Okay. I wanted to also to ask you, any operations done before for you or hospital admission?
No. Nothing.
Okay. Any awareness of your heartbeat?
No.
Okay. Any nausea?
Yes, I have some nausea. Some sickness.
You have vomiting?
No, only feeling sick.
You have tummy pain?
No.
You have difficulty with swallowing?
No.
You have any problem in your water work? You have difficulty or increased
No.
frequency or nothing? You have blood in your water work?
No.
No, sorry to ask regarding the, also I have forget to ask regarding any blood in your bowel?
No.
Okay, and no change also on your bowel habits?
No.
Okay. Any cold or warm intolerance? Weather preference? You have any weather preference?
No.
No weather preferences.
No.
Okay. Okay. You have any family history of your similar condition?
No.
Any diseases that run in your family?
No, doctor, no.
Okay. Do you smoke?
Yes.
How much and when you started?
10 cigarettes per day for the last 5 years.
10 cigarettes per day. Okay. Last of it. Okay. Smoking can affect your health, so better to stop smoking. If this is okay with you, I can refer you to the smoking cessation clinic. Okay. Do you drink alcohol?
No, no, doctor.
No drink alcohol. Okay.
No, no.
What is your job?
I am a teacher, doctor.
How these symptoms impact in your job?
It's affecting me a lot because I have fatigue. This is headache with, and nausea. Make me can doing my daily activity or going to my work.
I'm sorry really for this. Also, I will refer you to the social and occupational health clinic. They can help you. Any travel history?
Yes, doctor.
Where you went?
I went to Turkey 1 month
Yes.
ago.
1 month ago to Turkey. Yes.
Yes.
Okay. I want to ask, do you have any change of your color of your whites of eye?
No, no. It's okay.
Okay. Okay. Sorry to ask this question regarding, are you married?
Yes, doctor.
Okay. Since how long?
Since 5 years.
5 years. Is your wife has any disease or
No,
take any medication for any?
no, no. She's okay.
She doesn't have the same symptoms that you have.
No, no.
Okay. And sorry to ask this question regarding any marital relationship you have?
No, doctor, never.
Okay. Regarding, you told me that the GB told you that you have low sodium.
Yes.
Okay. You have this test so that I can see the level of the sodium, or what he
One.
told you, what medication he gave you?
What? Again?
The low sodium.
Hmm.
He told you that just low sodium, and he gave
He
you any
told.
medication? You have any
No,
symptoms?
no. He told me it is 125.
125.
Hmm.
Okay. He told me you don't have fever. Okay.
No.
Okay. So I wanted to do examination. Is this okay with you?
Yes, doctor.
First, I wanted to examine your chest. Okay.
Yes.
I will do an inspection. Any limitation of the movement by inspection?
No.
And then I will do the palpation of the chest. Also, there is no limitation. You told me. Okay.
No, no. Hmm.
I will make a percussion. Can you sing in the percussion?
This dullness in the lower end of the back.
Right side or left side or both?
Right side.
Right side. Stony dullness.
Yes.
Okay. I will make auscultation.
There is fine crepitation, which is a change with cough.
Fine crepitation change with cup. Okay. Also, I will make the hand. I will calculate the respiratory rate.
It is normal. يعني 117.
Pulse also.
Normal.
There is no clubbing.
No.
No pulmonary edema.
No.
Okay. I will auscultate the heart.
Normal.
Normal heart. Okay. Then I will make there is any proximal myopathy.
No.
No. I will go to the head. I will see there is any sclera jaundice or pallor.
No.
Tongue. No cyanosis.
No cyanosis.
No cyanosis in the tongue. Also the nails. There is no peripheral cyanosis.
Yes.
Okay. Then I will examine the lower limb regarding the power.
Normal.
Normal power. Okay. I will go to the tummy. I will examine superficial, then deep, any organomegaly.
No.
No organomegaly. Okay.
Mm.
I will examine the neck. Any lymph nodes?
No.
No. Any axillary lymph node also?
No.
No axillary lymph nodes. Okay. Short notice. Just social. Do you have any concern?
What I have, doctor, is it a cancer?
Your concern is valid, really. We should do our test and imaging before we can decide regarding the management. Okay. Because what I see is that you have this maybe there is water in the lining of the lung. Okay, so we will do tests. May will do also before imaging. Then may will take.
It is not a stony dullness of water. It is dullness only, not a stony dullness.
Okay, dullness on the right side of the back.
Yes.
Yeah, how many intercostal spaces is the dullness?
It is lower lung lobe.
Lower lung. Okay.
Lower right. Yes.
Yes. You told me regarding the travel history where you went. Turkey.
Yes.
Okay. But you told me there is no fever and there is no tummy pain.
No tummy pain, but fever at the start of the condition. Low
Just
grade.
you told me now.
2 minutes left.
Low grade.
Okay.
Yes.
Okay. So, okay. So loss of weight, loss of appetite, sweat, chest dullness, low sodium. You told me no, you don't have loose motion or
No.
you don't have.
Yes.
Okay. You can start examining the questions.
Okay, you're done with the concerns, all concerns?
No other concern you have?
No, it's my concern. This is the cancer. You answer the concern.
We should do our blood tests and we should do imaging also. Okay. Also for this headache, we should there is no only nausea. You told me that one. We should do also test for this headache also with imaging for the chest. Then we can do. We can sit with you with our consultant and we'll tell you the differential diagnosis. Is that okay with you?
Yes, doctor.
Okay.
Okay, let's go to the examiner question. Start, Dr. Lamia, please.
What's your differential diagnosis?
Okay, the findings, this patient, she has right-sided back dullness and she has low sodium 125. Also, she has headache. Okay. So I should consider lung cancer, especially small cell lung cancer, in my differential.
Yes.
Because she has loss of weight and loss of appetite.
Yes. What else?
What else? It can be a lung cancer with brain metastasis. It can be. Okay. Also, there is fever, you told me, but it is not high grade. We cannot also exclude the infection until we will see the pleural effusion
Which infection? Which type of infection here?
Because traveled to Turkey, I should do the other blood tests, also the liver functions, and to see if there is any affection. Maybe there is because she wanted to Turkey, maybe there is hepatitis A infection. That I should see the bilirubin and the liver function. Although there is no jaundice against this, there is no jaundice. Okay.
Yes. Your first differential, okay, small cell lung cancer
Yes.
associated with SIADA, which is cause hyponatremia. Yes.
Yes. Yes. Syndrome of unapproved
second-
antidiuretic hormone. Yes.
Yes. Second differential, which is a typical infection called Legionella. which
Legionella.
is-
Yes.
You should ask
And
about
Lanceta. Okay.
stay
I saw
in
for it. Yes.
hospital,
Yeah.
stay in hotel, which is,
Yes.
and
AC.
the key of these two differential is hyponatremia.
Yes. Yes.
Okay.
Yes.
A third differential is TB because of loss of weight, night sweat.
Yes. 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 Sure.
Okay.
Yes.
What investigation you will do?
We will do the investigations, just general investigation, CBC, RFT, LFT, and also the electrolytes, sodium, potassium, and also we'll add the calcium. Okay. And also we will do investigations regarding this Legionella antigen, I think. Okay.
Yes. Perfect. Yes.
Okay, and also for the TB, we'll make this sputum sample 3 repeated morning, I think, sputum sample. Okay, we will do imaging. We will do the chest X-ray. We will do CT scan. Also, I think we should, after the imaging of the chest, we can do for this imaging for the brain also. Okay. If it is malignancy or suspected, we can do the whole panel, see the brain, neck, chest, abdomen.
What do you
Okay.
think is the cause of this headache and nausea?
Headache and nausea, Legionella, it can do this neurological also, and also this can be brain metastasis because of the
Mild
lung.
headache and nausea, mostly due to hyponatremia.
Yes, yes.
Okay.
Also, TB also can be also TB meningitis. TB chest also can affect the brain.
Okay.
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 The treatment according to the what differential we will find of, if it is small cell lung cancer and there is metastasis of the brain, it will be palliative treatment according to the performance status of the patient, and maybe there is radiotherapy to the brain if there is brain metastasis. Maybe chemotherapy will be added accordingly, and the treatment of the Legionella will be antibiotics. I think erythromycin. I'm not
Levofloxacin.
sure.
Yes, levofloxacin or erythromycin.
Okay, levofloxacin or erythromycin. TB will be anti-tuberculous treatment. Okay.
What about this hyponatremia?
The hyponatremia, yes, this hyponatremia need treatment regarding it can be by this water restriction. Okay. And we'll see this, maybe we'll give this hypertonic saline. Okay. Also, this hyponatremia should be investigated. What is the cause? And
It is mostly
this
due to SIADA. Water
Yes.
restriction is okay because it's
Yes.
moderate and
Yes.
we follow up.
Yes.
Okay.
What
I
else?
don't have other question.
Okay.
Perfect.
Thank you. Well done.
You already filled the time, Dr. Lamia. 5 minutes already for the questions. Let's start the comment, please. Well done, Dr. Ahmed. Can you comment now, Dr. Lamia, please?
You did well, Dr. Ahmed, but يعني differential, you went away. I insist to tell you that there is hyponatremia to make your differential more conscious يعني with this cancer and Legionella.
Yes.
The most probably the differential يعني. But you asked well about the small cell cancer. And this the defect only in the travel history, I think you need to be asked in detail. The stay, you asked already about sexual casual relationship, but I don't know why you asked about the wife.
Because if infection can be chest infection, like a COVID or something, it can be transferred from the home, same family.
Okay. You can
They
also
have the same infection and diagnose mostly even like a TB. Maybe he has the same.
okay. You didn't ask anything about HIV also? There is risk here.
Yes.
Okay.
Also, I forgot.
Mm.
Yeah.
Um, uh, but did well anyway. I don't have other comment, Dr. Basim. You can complete, yeah.
Okay, the differential, Dr. Lamia, please.
Mm.
So you said TB, سيادة for
سيادة
secondary to
cancer,
cancer.
small cell lung cancer,
Yes, perfect.
legionella,
Legionella and TB.
TB, yes.
Okay, perfect. Any other comments you want to add? Because I have some comments also.
Yes, you can comment.
Okay, I will comment on the point of occupational for both of you. No need to mention occupational team for any scenario. Unless you can change the position to change the job, you can call them. Otherwise, you can provide sick leave safely to the patient if he's unable to do his job. Don't call any occupational team at all. Clear? So
Clear.
whenever the patient is having problem in his work, we will provide you with sick leave until you are okay and suits for you to resume your job. This is the best answer. And I did it twice and I got full mark. It's nothing bad to mention and to provide sick leave. You can provide sick leave.
Again, please, Dr. Best.
You can provide sick leave for any patient his job is impacted by his symptoms or complaint. No need to refer the patient to occupational therapy or occupational worker as you did. You and Dr. Ahmed. Both of you
Yes.
refer the patient to occupational work. So you can say if the job impacted by his symptoms, you can say I can give you sick leave until you are okay to resume your job. Okay?
Okay.
So if any patient unable to do his job or activity at job, provide him with sick leave. But if he told you I don't have any power at home, you can support him with social work. But
Yes.
occupational, we are not inviting this occupational team at all. Okay, this is regarding the job and the impact and how to solve it. Back to the history taking, you have two complaints. So simply you will analyze first one, then the second one, and try to collect what is related between both of them. You follow, I think, the approach I already shared before. So you start analysis of the onset, cause, duration, the relevant system, the cough, but you didn't ask about coughing up blood, right? You ask?
لا, he
No,
asked.
I asked this.
Okay.
He asked.
Remember always, whenever you have chesty patient means coming with coming with short of breath, coughing up blood. Always ask any contact with sick patient, particularly disease called tuberculosis, especially if he has travel history to India or some countries endemic with TB. You must ask this question. Why? If he said, yes, doctor, I had a travel or I had cousin with TB or my father at home having TB first differential in your case. Okay. So you have to ask this question to roll out or to put it in your differential as a TB. Clear, it's a very serious differential. And it might be the case, particularly if the patient is having night sweat, night fever, loss of weight, and coughing up blood. Okay, this
Okay.
is regarding the chest symptoms and chest analysis. As Dr. Aisha said or wrote, lung doctor or chest doctor, I agree to mention both of them. But if you are in doubt how to mention it, I am one of the doctors here. Easily. I am one of the doctors here. If you are in doubt about the clinic name in non-jargon way. This is for the introduction. Okay, let's go ahead with the other symptom. You said about loss of weight. You analyze it well. Any association with appetite? Yes, it's good to ask about this question. And lumps or bumps. to put HIV or any serious infection again one of the differential because you have alarming constitutional symptoms: loss of weight, loss of appetite, night sweats, night fever, and lumps or bumps. The system review you did great, but your question, like, you are judgmental. You are saying you said no diarrhea, right? No, you can ask, do you have or no? Don't judge the patient is not having. You don't know. Don't assume the patient is having diarrhea or is having something is negative. And try to write what is the positive in the history, because if you are repeating the question, means you are not focusing while taking the history. You repeat the question at the end. You are you sure you told me that you don't have diarrhea, right? So if you are writing the positive thing and the negative things, you will not ask this question at the end. This is regarding the system review, and I think you missed the genitourinary. You didn't ask about the urine,
He
Dr.
asked
Ahmed.
already.
He asked urine.
Yes, yes.
Okay, so he asks skin rash, skin and joint pain, skin rash, the GI,
I think
feeling sick, yeah, feeling sick, vomiting,
mm,
feeling sick for nausea, and throwing up for vomiting. This is in non-jargon way. So don't ask you have nausea or vomiting. The headache. Yes, he asked about alarming sign of headache. Is it increasing while bending forward or with coughing or sneezing? This is for alarming or increase in tachycardia pressure signs and symptoms in the history taking. The socially you ask about everything, but as Dr. Islamia said, no need to ask about since when the marriage or he has his wife. You have partner or no? Yes. Okay, good. You have any, sorry for this, any casual relationships or extramarital relationships? Yes. If yes, you can ask another question. Is it protected or no? We are not here to judge on his relationships. We are asking for the health related problem. So if you want to screen, do you have any casual relationships? Yes, doctor. You have to be sorry before asking this question. If he said yes, so the next thing, is it protected or no? He said no, it's not protected. This is the time to advise him instantly. Don't leave this point to the end, because if you skip, you will miss it. So what to do? Immediately advise him, sorry, in your conditions, since you have some possible infections, and you are having this risky habit, I can advise you either to use protected sex. That's it. So don't ask advice not to have another casual relationship. So you are not here to judge on him if he will not have or he will have. He might have, but please use protected sex. Okay, clear this point. Again, the travel history, as Dr.
Yes,
Lamia
clear.
said, yeah, whenever you have travel history, analyze it. To where and what is related to the travel in your scenario. Here you have cough and chest symptoms. You have to analyze any chest disease in the area you went. So TB, you have to roll it out. The EC system, you suspect like Legionella, and Legionella related to the
Yes,
AC
air
system,
conditioner.
right?
Yes.
Air conditioner. So you can ask any problem, anyone in if in the family or the group, if he travel with the group, anyone in the group had the same problem or only you. So if anyone else has the problem, it might be related to the hotel. If the travel history to endemic area with malaria, you have to ask about prophylaxis for malaria. Don't forget to ask about allergy in this condition. You gonna prescribe medication, antibiotics for this patient. If you don't ask about the allergy history, you might give him penicillin or any medication that might be allergic for him and he will have allergic attack. So allergy added to always to the past medical history of any condition. If he said what you mean, you can specify high blood pressure, high blood sugar. Don't ask about low blood pressure or low. You ask about low blood pressure, right? But it's high blood pressure
Yes.
for the
Because I
hypertension and
suspected
hypotension.
also Addison. I suspected Addison. Maybe he's taking something corticosteroids or something like this.
Okay, you can ask specifically any medication you are taking. If he said no, doctor, you can specify steroid. If you suspect, for example, Addison. If he said no, tell him again, show me your medication list. Definitely, they have medication list in the places. They want to waste some time reading the medication list and to put your differential, either to pick up some medication might be the reason of your condition. For example, in this scenario, maybe the patient, as you said, is taking a steroid, immunocompromised. So you can suspect BCB, for example, but it's not the case. Or he can take diuresis or diuretics, and you might correlate the hyponatremia due to diuretics. So you have to check his medication list. Again, the past medical history, including past medical, any long-standing disease, any medication, any over-counter medication, any herbal remedies, any surgery, any procedure, any allergy. Quickly, it will not take time. Train yourself to ask all these questions once as a package. Don't ask one question and go to another part of your history. You will miss the other question. I mean, other or other history, like surgical history. Here, it might be important to ask about surgical. Maybe patient have pleural effusion and he did tapping. It might be like parapneumonic infection. So it's important to screen about every single history in the past medical history. Any admission, some doctors also want to ask about any hospital admission. Yeah, maybe a patient admitted to the hospital, received antibiotics, and the antibiotics the reason of Clostridium difficile, for example, pseudomembranous colitis, like that. So in this way, you will pick up most of the finding, and you will get, of course, good mark or maybe the full mark. I think this is for the history. And do you smoke? Do you drink alcohol? Yes, and advice regarding the smoking, then the job, impact on the job, sick leave if he needs, and finally the examination. I think the examination here, full chest examination, full steps of chest inspection, palpation, percussion, auscultation. I thought you will miss the lymph node, but you did it at the end. You examined the lymph node, which is very important in this scenario. And finally, the concern, please, if she asks you clearly, is it a cancer? Tell her clearly, yes, one of the possibility is a cancer. You didn't say this is a cancer. I mean, you didn't tell in granted way that it is a cancer, but you said it's possibly to be a cancer. You have to be clear in your answer. Don't say we have to run some blood test to answer you. So what the benefit of this discussion?
I am afraid
This
regarding as he told me, I told the bad news regarding or something like that one
yes, but she's
regarding
concerned
yeah,
about that.
yeah,
She's concerned
yes,
about cancer possibility. So be clear about, and you have the possibility of cancer. You have loss of weight, you have loss of appetite, you have a night sweat, fever. Still cancer, one of the possibility. And you didn't say this is 100% cancer. You said there is a
yes,
possibility of cancer, right? Just give a clue that there is possibility. Then let the other possibility for other differential. And don't say, as Dr. Aisha said, don't say differential. Patient doesn't know what's the meaning of differential. So there is other possibility. We will admit you. We will run some blood tests to confirm the most possible condition and to rule out other possible conditions. Simply, okay? By this way,
okay,
believe me, you will get full mark. So you have to
yes,
answer the concern to the patient like you are talking to the examiner. Why you mentioned the cancer to the examiner? Once he asked you, you said yes, there is possibility of cancer, and you hide to the patient. They will say or they will comment that you are not honest with the patient. Be honest. This is what we are practicing in our life. If there is possibility, yes, we have to mention to the patient that we have possibility. Okay, the discussing questions was clear. You did most of the questions. Perfect. Legionella, hyponatremia, sciatica as small cell lung cancer. The investigation, as we mentioned again, general, specific, bedside, non-invasive, and invasive, and if for complication. General here, you can do all workup, including electrolyte. Very important here to do electrolyte. Why? Hyponatremia. Specific test here, what you will do, Dr.
I think
Ahmed?
as also ACTH should be done also.
Perfect. So specific ACTH,
Yes.
other hormonal assay, and one more important for the osmolarity and so serum osmolarity and urine osmolarity. You want to confirm SIADA,
Yeah.
right? Urine osmolarity,
Yes.
one
Yeah.
of the confirmatory tests for SIADA. Urine osmolarity more than 500. Then we will go to tumor markers. You can mention tumor markers. You suspect cancer, TB workup. All this under the term of specific. The bedside test. What bedside test you want to do here? Bedside test. ABG. Always remember ABG in any chest case. ABG.
Yes.
Spirometry. Pulse oximetry. Okay, these are the bedside possible tests. ECG, echo, according to the case. Then the non-invasive test, what you want to do? Imaging. Imaging. What image you want to do here? Start always with
Chest
the
X-ray
simple
and
one.
yes.
Perfect. Chest X-ray. The first initial imaging to do in any patient with chest symptoms is the chest X-ray. I will do chest X-ray. If you have suspicion of cancer or possibility of lesion, what you will do?
The CT then.
As an imaging. Perfect. I will
If
do CT chest with contrast. If I have high possibility of cancer, I will do
bed
CT
CT also.
CT cap.
Yeah.
CT
Yes.
cap.
Yes.
CT cap. Just abdomen and pelvis.
Including brain because of
Okay.
the
The
lung.
last. Okay. Yes. If you suspect brain mets, yes, you have to mention the brain as CT with contrast. So pan CT for staging
Yeah.
and looking for the secondaries. The last test to do. What invasive test you have to do here?
The
It's to the
pleural tap,
target.
pleural aspirate
If there is pleural
fusion.
effusion, okay.
Yes.
If there is no pleural effusion, what target invasive test you want to do?
Biopsy for the lung.
Perfect. That's it. Biopsy, whatever the maneuver and the approach, either transbronchial or CT guided. Okay.
Yes.
And the last question or the last investigation, I think we finished the most important investigation here. Smoking, you have to mention, of course, as a trigger. He's heavy smoker, 10 cigarettes per day. The management plan, treatment of the underlying cause. Legionella, macrolides. Don't specify antibiotics by name, like macrolide or quinolone, levofloxacin, or macrolide like azithromycin. This is for the Legionella. If you suspect cancer, so better to start with multidisciplinary team approach, including pulmonologist, oncologist, and if you suspect brain lesions, neurosurgery, physiotherapy, respiratory therapist, okay, chest,
Yeah.
yes, respiratory therapist. Then this is the non counseling education about the condition and the disease. This is the non-pharmacological. The pharmacological. So if you have cancer, the patient will undergo either chemo, radio, whatever the cause of his cancer should be managed accordingly. If he's in advanced stage, as you said, he could undergo the palliative therapy. And if infection, so I will start with antibiotics as I mentioned. If TB, what the first thing to do if the patient suspected to be TB? This is what we are practically doing, starting
Isolation.
isolation. Perfect, yes, isolation. Isolate until confirm he's not open to be TB 3 AFB sample. If confirm is not, we will remove isolation. Of course, TB PCR we have to do also, and continue management plan with the infection control and IDT. Simply. Okay, no need to mention the anti-TB, the name, if they ask in deep, they will not reach to this level, by the way. If you reach to the management plan after all the question I mentioned, it will be just non-pharmacological, pharmacological, and the bell will be ringed. Clear now all this case. I think this is the case, Dr. Ramia. Any question or
Yes.
comment you want to add?
No,
Really
no.
appreciate it, Dr. Basim. Thank you very much. Really.
Most welcome, Doctor. I will ask Dr. Lamia about the headache here only. What's the relation? Is it brain lesion
Due
really
to
or
hyponatremia, mild or moderate
yes?
hyponatremia cause nausea and headache.
Yes, I agree for this. Yes.
Mm.
So it's sciatica causing or hyponatremia. So, by the way, hyponatremia might present with any CNS manifestation,
Yes.
from even simple headache up to seizure
Yes.
and confusion and coma even.
Yes.
So be simple in the thinking. Don't think it's advanced and brain lesion, and you have some cause, simple cause like hyponatremia. Severe hyponatremia can cause even seizure. Patient, if you ask more, a patient might have seizure because of hyponatremia. And the management of SIADA is very important to mention. As you said, Dr. Ahmed, it's fluid restriction, 1 liter for 24 hours, monitoring of sodium level Q for hours, avoid rapid correction of sodium more than 10 millimole for 24 hours, plus admission to ITU or ICU if the patient is having CNS manifestation or seizure or comatose. Okay?
Yes.
Thank you,
Okay.
Dr. Bas.
Any- Most welcome, Dr. Lamia. Thank you too. Thank you, Dr. Ahmed, for the practice. Any question before opening the discussion with others?
Mm.
Okay, if no question, any comment from others? I can see some comments, but anyone want to comment before reading? Dr. Aisha, you are here? Yes. Your comment, Dr. Aisha, please. Okay, maybe she's busy.
Nothing. You said everything. Thank you.
Any missed point by me? Because sometimes I miss some points. If you have any comments.
Just I suspect this is more infection because the acute, يعني it is
Yeah,
7
acute
weeks,
presentation.
not. So for me, I'll put the infection first because also traveling to Turkey, it is happened. Then the cancer, because it is
Perfect.
dangerous, so you need to exclude it. But I think it may be abscess and complicated, yeah, not just infection, because the dullness and the long course and the virulent sputum may be also like I said, like infection complicated by some abscess or
Perfect. Yes.
cavities, yeah.
Yeah, I agree with that because it's
Mm.
acute presentation.
And
And whenever, yeah,
الage
go
also.
ahead.
الage also 31 years old.
Yeah,
Mm.
Yes.
you're right. Whenever you have first presentation, you have to ask about previous presentation. Because if it is recurrent, you might suspect cancer or immunocompromised patient with recurrent infection. But if first time, you suspect acute condition like as Dr. Aisha said, chest infection, whatever the cause and the organism. Okay, there was question, good question about, thank you, Dr. Aisha, for your comment. Possibility of, yes, Legionella, we mentioned TB. Yeah, your comment is very nice, Dr. Aisha. Lung clinic, not appropriate, so you can say chest, agree. The word differential for the patient is not appropriate, I agree. Also, it's jargon, so better to say possibilities. Doctor, one of the doctors here in the clinic, I agree, it's good general term. Legionella, yes. Dr. Salma said this is new today. Yes, I believe we have a lot of a variety of cases. Really, it's good. Both cases are good. Mycoplasma is not. Yes, someone asked about hyponatremia with mycoplasma. So mycoplasma mainly it will present with the hemolysis, yes, and some GI symptoms rather than hyponatremia. But again, the GI symptoms like vomiting or diarrhea might lead to hyponatremia. So it's not common, but it can happen. Mycoplasma cause hyponatremia. Yes, I mentioned that. And GI symptom, exactly. I don't know if you said bronchoscopy plus or minus biopsy, CT chest, abdomen, pelvis for workup of cancer. Yes, I mentioned that, Dr. Zainab. Thank you for this comment. Uh, yeah, again, no need to mention since when you are married. It's just you have a partner. Yes, you have any other or casual relationships. If it is positive, is it protected or no? If not protected, advise him to have protected sex. That's it. Don't go deep, whatever the patient, gender, or religion. Contact with coughing person. Of course, Dr. Rashid, you have to ask this question, TB. And Dr. Zainab, again, also include workup for hyponatremia. Perfect. Cortisol, thyroid function, serum, urine osmolarity. Perfect. We mentioned already. Thank you. PPI, also one of the medication cause hyponatremia, not only steroid cause hyponatremia. That's why, please, in the first scenario, in the second scenario, drug induced is very important differential. Please have a look to the medication list. The medication history is very important. Show me your medication list. You must ask this question. If you miss it, you miss a differential. They put all with the differential related to some medication as a differential, not as a cause. Unless it is a cause, it might be a differential. So either a cause to the complaint, like skin rash, for example, drug induced, hyponatremia, drug induced. If you miss it as a case presentation due to this medication, it will be missed in the differential. So you can say differential diagnosis, drug induced, like hyponatremia due to thiazide or diuretics. So have a look always. PPI, yes, I agree. If you find in the medication list pantoprazole, PPI, you can link it to the hyponatremia. He overlooked calcium concern. Calcium, yeah, it's okay.
patient concern.
لا حاجة
Patient,
بيتجاهل الكونسيرن بتاع البيشن هو.
yeah. Yeah, that's why I
He didn't
address.
address the concern of cancer.
Yes, so please answer clearly. It harmed the marks for consent. Okay.
Sorry for this. Regarding overlooked the patient concern, overlooked, it means I think asked a lot regarding the
No,
concern,
no, no,
isn't
no,
it?
no.
Or
No, you
pass?
No,
didn't
you neglect.
answer.
You neglect. أنت متعمد
Neglect.
يعني تتجاهل.
Yeah, yes,
Okay.
exactly.
It
Usually
means
it's the
neglect.
feedback they are sending for you. If you didn't answer well, they
Perfect.
send it like this.
Yes.
Yes. Okay.
So the question is it a cancer? The question is it mean you have to answer either yes or no. Don't put or answer him with a twisty way. Don't say I actually we will admit you to see if it is no. Clearly, I'm afraid to say there is possibility of cancer. So you give him, even it was shocking, but this is the real. There is possibility. So don't
Give
twist
a
the answer.
justification also. Or mention justification for
Yeah.
that.
Yes, agree.
Okay.
Okay. Dr. Hatim, is this patient for admission or it can be deal with outpatient? I don't think he's for outpatient. Patient is having cough, loss of weight, any patient with constitutional symptoms, please either to refer to the specialty or to admit him until he will be clear of infection or whatever. For example, if you suspect TB, how you can discharge patient with possibility of TBs? It's unsafe for the patient and for the culture. If he has open TB, for example, and you just discharge him, it's unsafe and you'll be unsafe, doctor, for the welfare and also for the clinical judgment. Also, blood clotting history better to be fixed in past medical history besides surgery procedure, hospitalization. Oh yes, I agree. If you have history of clot or something, TIA, the complaint itself will direct you to this question. So you can ask it whatever or whenever you have possibility of clot, but not in every patient. Okay, OCP, yes, you can ask in female history in every patient. But clotting, why I will ask clotting in this scenario? You suspect PE, for example, but it's not
No,
going
not
with PE.
related.
So
Here, not related. Yes, but whenever you
yeah, you
mention
can put it in your
hospitalization,
approach.
surgery,
Okay,
better
okay,
تركيز يعني. لأن ده بذكرك
okay. Put it
الحاجات.
in the approach. Yeah, put it in the approach, but don't ask as an irrelevant question. Because he will ask you why, or he will comment on that. Why he asked about clot history with patients of chest symptoms with the infection. Unless he has, for example, hypoxia, short of breath, yes. You suspect pulmonary embolism, yes. You have to ask. Clear? Thank you, Dr. Rashid. It's a good idea also to add it to the approach. Any question else? Any comment? Today the attendance is very, I don't know what happened anyway. It was a nice session really by Dr. Ahmed and Dr. Lamia. They did great. I
Assalamu
appreciate to
alaikum,
start.
Dr. Basim.
Alaikum salam, yes.
I have 2 comments or 3 comments.
Dr. Sara,
Uh,
yes.
yes. Number 1, he did great, but during taking history, he's asking judgmental question. He didn't
Really?
ask by open question.
Yes, yes.
Mainly at the systemic review. He must ask about this by open question, and then he can ask about any symptoms differently or individually,
Yes,
not
I
short
agree.
symptoms.
Yes,
Okay.
yes.
Then he always saying okay. I think it's not good to say after every questions okay.
Okay.
Also, when he's inquiring about HIV, he asked just about the extramarital relationship. He
Yes,
didn't ask
yes,
about sharing needles, tattooing, blood transfusion, and
yes.
this.
I agree. If he has a risky habit, once
Yes.
he should screen the others. Yes, you're right.
Okay. Thank you.
Just I am showing regarding this. Okay, I'm telling just I make active listening for the patient.
Mm-hmm. It's
Yeah, and I
okay.
wanted to there is active listening. So she tell me or he tell me regarding the symptoms. I'm telling okay. Yeah, I can change
I
it. I
heard,
make it
yes.
understandable.
Or well,
Really
you
like
can
that one, but
say well, well.
because
I
of the
like
time.
the no. I like the word well, well. It's
Well,
okay. The same well, yes, well.
yeah.
It's like you are listening and you heard it. Yeah, and also it's good to mention it's well. Okay, if you want to train on that, it's good. Okay. I
Well,
want to add also well. Yes, well, exactly. Not okay. You can say well. I will add last comment for Dr. Lemia and Dr. Ahmed and everyone. In the introduction, just introduce yourself. I am Dr. X. You are Mrs. X or Mr. X. I am the doctor here. You are the patient name and the age. I will, what you will do, the agenda of the meeting. I will take history, examine, address your concern. Go ahead with the complaint. Whenever you are saying, yes, I'm here, everything will be confidential, it will waste 1 minute. I noticed with Dr. Lamia, she took 1 minute to say or to introduce or to make this introduction. I'm here to take history and to be confidential. I will make a note. All these things waste a minute, and you need the second at the end. Believe me, 1 second you will need it to do some examination, which give you mark. So the best thing. I am Dr. X, one of the doctors here. You are Mr. X. You are 50 years. I'm here to address, to take history from you and to examine you and to address your concern. Is that okay? Yes, doctor. Please go ahead. Start you have a condition called or you have a complaint of headache or whatever. Then continue the analysis. Try to make it in 30 seconds. Train on that. 30-second maximum is enough. Even if shorter than this, it would be much better. Okay. Any
Okay.
question or any comment?
No, thank you, Dr. Bess.
Most welcome, Dr.
Thank you very
Amir.
much, really.
Most welcome. You
Appreciate it.
deserve the best, inshallah. Best of luck to
Thank you.
both of you and all of you. Hopefully, we'll meet tomorrow with the communication day. If no question, we can end the session. Okay. Seems satisfied, all of you. Now the time to end the
Yes.
session. Good luck and good night. Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you, Dr. Ahmed, Dr. Lamia.
Thank you very much.